Good afternoon. Thank you for logging into today's presentation in the Accelerating Initiative webinar series. The presentation will begin shortly. If you have any questions during the presentation, please enter them into either the Q&A box or the chat box, and they will be answered during the Q&A portion of today's presentation. Thank you.
Good afternoon. This is Barbara Brandt, Director of the National Center for Interprofessional Practice and Education. Thank you for joining today for another webinar in the Accelerating Interprofessional Community-Based Education and Practice series. Today, we're delighted that we're hearing from Creighton University, and the title of their presentation today is Cultivating Collaboration, Building a Successful Collaborative Care Model in an Academic Health Partnership Teams. Sean? This activity is available for continuing education credits, and this is the screen that tells how to get the credits for various professions. None of the presenters today have a consulting, are disclosing a conflict of interest. One participant, Kyle Turner, has a consulting relationship with Primary Care Progress, but not a commercial interest. I've introduced myself as one of the facilitators, and another is Carla Dieter, who is the coordinator for the Accelerating Initiative and Nexus IPE programs in the National Center. Today's presenters on the webinar are Megan Potoff, and she was and is the principal investigator for the Accelerating Initiative, and she is in the College of Nursing at Creighton University, and Joy Dahl, who is the executive director of the Center for Interprofessional Practice and Education and Research, as well as in the School of Pharmacy and Health Professions. And they are representing a very large, I might add, interprofessional teams of clinicians and academic professionals. So today's objectives of the webinar is to discuss how the Nexus IPE team was able to implement an academic practice partnership called the Nexus. They will describe how a team of students and health professionals actively learned and worked together with people to improve health and well-being in the community. They will be giving us key lessons learned, as well as an application of one of the tools that we use when we coach similar implementations. Carla?
Yes, and this particular slide highlights the basics of the Accelerating Initiative. We do want to give our thanks to the John A. Hartford Foundation, the Robert Ward Johnson Foundation, Josiah Macy Jr. Foundation, and the Gordon and Betty Moore Foundation for their support. But in lieu of really going through all the specifics of this, we will be showing where you can learn more about this initiative on one of our last slides. So we want to make sure that we have enough time to really delve into Creighton's initiative. Next slide. We've been trying to do this with each one of our presentations and say these are the basics. This webinar in one slide. Obviously, the future is interprofessional. All of our presenters in this series are talking about what they did in community and practice, and the focus is really first on the people, patients, clients, families, and communities, not the professionals and students. And they'll be telling you how this really works out for everyone. And then what's different is the nexus. And that definition is redesigning both healthcare education and healthcare delivery simultaneously to be better integrated and more interprofessional while demonstrating outcomes. They've got some wonderful goals to be highlighted, and then their key lessons are noted here, and their outcomes are also very interesting and exciting. And the two tools that they will be talking about is the IOM IPLC model and the stair-step developmental model. And so with this, I'm going to turn this over to Megan and Joy.
Hi, this is Megan Potoff, and I'm going to start off, and Joy and I will kind of go back and forth. So just to start off, this was what our partnership, this is a pretty basic, simplistic version of it, but our community partner was our academic health partner, CHI Health, specifically a new clinic / outpatient center that had multidisciplinary or interdisciplinary model there that was being built and started from new. So we had clinics coming from 2 existing locations coming together in this new center. And then on the academic side, the College of Nursing, the Center for Interprofessional Practice, Education and Research, and the School of Medicine were our main players from the academic side.
Thanks, Megan. This is Joy. So our context was really focused on providing better care for the people in our community. One of the unique things about the site is that it has a refugee contract for the state, so a lot of diverse patient population and vulnerable needs. And then our context was kind of interesting. So leaders from CYPER and from it was previously unnamed university campus were asked to help design the site from the ground up to be an interprofessional learning laboratory in addition to a clinical site. So our collaboration aligned at the time the grant call came out, and we actually wrote the grant before the clinic was open. So had to try to vision what this would look like before actually having the clinic built. Next slide.
So our compelling vision really focused on how, like Joy said, we kind of developed this vision and this clinic before we had the building built, but we knew that the purpose was to serve the community with innovative, value-based healthcare, education, and research. And we wanted the capacity for good interprofessional learning that could meet the medical needs of these complex, large, diverse population in our kind of high-risk area. So the vision was to focus around that using high-quality interprofessional care. And then we really wanted to focus on patient-centered outcomes so that we could translate the model of care.
And our vision played out in keeping the team focused. So we learned some good lessons. So we learned that a way to get the clinic trained was to use the 5th Friday. So there's so many Fridays a year that are the 5th Friday of the month. And we were informed that there's considered a little bit of an extra revenue day. So we're able to do that, and we continue to do that. We have our next one on January 31st. So that was helpful because it's difficult to get people out of clinical time to train and educate them and prepare them to work in teams. We're lucky at our institution to have a great department that focuses on conflict engagement and resolution. And so we were able to work with them to provide focused training on conflict engagement for all the clinic staff. And our clinic leadership were really at the table from day one and considered a valued member. To Barbara Brandt's point, our team is large, and our healthcare administrator was always part of our team, actually came with us to the grant workshop and was always part of the project. And then our trainings are inclusive, so we train everyone from front desk all the way. Every position in the clinic is invited and participates. And then we implemented clinical processes that allow for collaboration. So we have twice a daily huddles, and then we have collaborative care planning, which was where the team gets around a high-risk, high-utilizer patient. And that's really kind of the group of people we did our research on, even though the model was open to everybody. So those are just some examples of things we've learned that were best practices after the clinic opened and we got started. Next slide. Yep. Oh, so our team collaboration has really been focusing on the process for team huddles, what the collaborative care planning looks like, and how you document that in an electronic health record. And we've gone back and forth with pre-visit planning as a way to help collaborate as well. And we really try to share the lead between all the disciplines, including behavioral health, diabetes education, our interpreters, medicine, our medical assistants, basically everyone on the team. Anyone can kind of step up at any time and bring things forward, and we really try to have a shared leadership model. And really, one of the imperative things that we didn't have one profession identify as a lead, rather we identified champions who help with the process and really support our huddles and our collaborative care process. So people that run the huddles, that make sure the patients are identified for the collaborative care process. And sometimes instead of saying, oh, to certain professions, that's your role, we let people kind of identify and emerge as champions in those areas.
Okay, so we'll talk a little bit about our outcomes. And Joy mentioned the clinic was open, the interprofessional model was open to everybody, but for our outcomes, we identified high-risk population based off of 3 or more ED visits, their LACE score, or an A1C value. And that's how they qualified as a high risk. And then we use those also then as those were what qualified them to get them into our study group. And then we tracked their ED visits, hospitalizations, and A1Cs from the year before the new clinic opened and then the year after. And we're still tracking that group as well as adding new cohorts. But what we found comparing the year prior to opening this newly designed interprofessional clinic to a year being managed and treated as part of this clinic, our ED visits went down in that group, which our N was roughly 248, I think, right, Joy? Down there. So ED visits went down 16.7%, hospitalizations reduced 17.7%, and then the A1C values, we saw 0.8% reduction. We also tracked patient charges. This isn't a true cost outcome, but it was the best we could get. As far as we can't say dollars saved by the system, but we can say that we reduced the charges on this group of patients by 48.2%. When we look at patients with at least one ED visit and or hospitalization in 2016, there was also a significant decrease in the average number of visits and hospitalizations in 2017. So we saw changes across the board there. The other outcome that we didn't set out as our initial outcome, but the employees that came into this clinic came from 2 separate clinics, and their employee engagement surveys at their clinics prior to coming to this one were some of the least satisfied or least engaged. And a year after moving into the new clinic, their employee engagement surveys were in the top 3 in the system. Next slide.
All right, so some of our health system outcomes is that the collaborative care model has really improved the employee satisfaction at the clinic, as Megan mentioned, which is really important for the 4th aim of the quadruple aim, looking at clinician wellness. And it really moved up. And so that was, again, an unintended consequence of teaching people to collaborate. And according to the recent patient surveys, the clinic is also in the top 5 as out of the over 150 CHI clinics to be recommended by patients. So also positive patient experience there. And one of the wonderful things, because of our cost savings and a way to, avoid charges, as Megan alluded to, we were one of the first care clinics in the system to move to CPC Plus by Medicare, which is a values-based payment structure, because we've shown that interprofessional work can be effective to reduce cost. And so there were 2 clinics out of over 151 that were chosen, and University Campus was one of them. And then the other thing that happened is that we became a place to visit. So we've had other institutions come visit us and learn what we do. From other universities and other clinical sites. And then we actually invited and had a recent a visit from the director of Medicaid in Nebraska and are working to collaborate with them about how we'll move our metrics forward and what we'll look at next to demonstrate not just for our health system, but our state what the impact of interprofessional practice can mean. And then we have an intentional interprofessional clinical learning environment. So that serves as that site for many learners. And one example is that students participate on our interprofessional education passport in attending and observing a huddle and then writing a reflection. And so the reflections are really positive where students see, wow, look at all the professionals available to work with a patient and what it looks like for them to collaborate all in one room. It's a pretty simple exercise because it's not a huge time commitment, but pretty powerful. And we've discovered some structural barriers to the interprofessional clinical learning environment, one of which is onboarding, that not all our health professions were onboarded to the clinical sites at the same time. And we've now standardized and streamlined that so that in fall 2020, we'll be able to have all our over 1,000 learners onboarded by hopefully October of each year. And then we can do more intentional activities in the clinical learning environment. We're exploring a new site for another clinic, and then we recently added chaplain residents to the interprofessional team, so that's been an exciting advancement. And then our key lessons of, certainly there's many, as Meg and I have learned a lot, and so the rest of our team has. We're grateful to have been on this journey, and we learned that the importance of focusing on community needs and looking at what the community needs, and that collaborative care yields insights beyond traditional health education, with the power of having the experience. And then really the opportunity to create program structures aligned with the Nexus site goals and look at what does it mean to have both the academic and the clinical learning for interprofessional, and how you reinforce and support both and how they learn to work together successfully. And then for sustainability, the importance of buy-in from the healthcare system. So one of the things we did was that we got the health system to agree to hire a nurse practitioner on site, not supported by the grant funding, but by the system. So when we got the grant, they did that, they followed through, and they've also hired a physician assistant now. And that member, the nurse practitioner and the PA are fully integrated as part of the team, very well accepted, and has been great to move forward and also provide examples to our learners about our professions working together. Our student structure and growth, we continue to expand opportunities for students to have access to learning in that environment. And then really the academic health partnership, where both organizations' shared mission promotes experimenting with some of these things and figuring out what works best, and really working together to move them forward.
Okay, so I'm going to talk, this is one of the models that the National Center provided as we started the grant. That was very helpful for us. In particular, the stair-step model was super helpful in the sense that we were a unique blend of collaboration, in the sense that we had two groups of clinicians coming from different sites into this new site. And then also kind of new faces to some of that was the academic side. So for example, I am a pediatric nurse practitioner by training, and clinically this wasn't my place to practice, but I was coming in as a PhD researcher to help as the PI of the grant. So we brought a bunch of people together. So really, when we looked at this stair-step model, I think the important parts were at the beginning and the getting to know you. There were familiar faces at the beginning that came together to write the grant, a team of 4 to 6 of us. But as we got ready to implement, we recognized as a team the importance and the training that we provided, as Joy referenced, the Fifth Friday training, and being intentional about not just putting the model on, but building in training. And with that training came this getting to know each other, which I think helped with the investment of all the employees, both in the clinic who weren't a part of the initial writing of the grant, but were key, were the champions of carrying out the work and the actual on the ground boots that were really important. So then because of that, I think we're able to see our teamwork really excel. There was a fair amount of trust that I think is hard to come by in the healthcare system when you don't invest time in that. And then we really kind of focused on those two for that first 6 months of the beginning part of our grant. And then with that, we started to look at patient outcomes. And I think because of spending time on those first two steps, we were able to see our positive outcomes in our patient population that we talked about. And then the ultimately, when we started this, we kind of starred the first three as our targets, and then also the health and patient outcomes. I didn't think as the PI driving cost out of the system was going to be achievable. That seemed like a lot, but we were able to see some of that with our cost outcome. And I think that really was this model was very important for us to be able to move up to that level of outcome, improved health.
All right, so we took also the interprofessional learning continuum and reflected a little bit on where we feel, and this isn't every detail, but where we felt we are, and it was a helpful model as well. So we in our team acknowledge everyone is a learner. One of our mottos is everyone teaches, everyone learns, and it's training for all, and all are part of the team. And that's been a really important part, that everyone is on a learning continuum and we all have something to offer and we all have something to give, and how important that is for setting the tone for the learners and for the culture in a learning environment. And then when we think about enabling and interfering factors, it's a challenge to implement collaborative care in a relative value unit fee-for-service system where there's a lot of pressure for productivity. And so we actually do our collaborative care meetings during the lunch hour to avoid billable time. But it also did allow us the opportunity to advance values-based payments in our local area, which is a huge opportunity. And then when we think about our health and system outcomes, we really structured our metrics plan around the quadruple aim, initially the triple aim, but then we had the employee engagement be a benefit. So it met the quadruple aim, which again, an unintended but positive consequence. And then our learning outcomes, we used the ACE 15 for our clinicians. So they did that at every training. And then we have qualitative assessment on, for example, the Huddle experiences the students are having, and we continue to look at those data points as we can move on. We focus first really on our clinical outcomes. So this model kind of helped us frame, and obviously these are just little snippets of things we learned as we think about the model comprehensively.
I think before we, do you want to back up, Sean, Diego? I think before we, move on I'd like to have Megan and Joy talk a little bit more about what, the community that you're actually serving, and give a little bit more detail about how this clinic, why did this clinic end up being built, and what was happening? What was your context in that part of the community, and what those needs of that community was, and what whole some of the changes made, and why you were focusing on this and bringing these two clinics, very different people who maybe didn't really want to be brought together in the beginning, and how some of this all came about. But first, focusing on what was that need in the community?
I think Joy and Megan, this is Barb. I just want to tell you that Carla and I are teachers, and we're going to ask you a lot of questions. You have much to teach a lot of people, so go for it.
I think the biggest thing, and Joy can expand more, but a big part of it was the social determinants of health and wanting both of our academic, being a Jesuit university, that's a focus of how we teach our learners and where we center our health profession teaching from. And then our academic partner, CHI Health, also has a similar mission. And so we were still at the time, back in 2016, this was still a pretty raw, fresh relationship where we were becoming a recognized academic health partner with CHI Health. And there were some bumps in the road to that, but it seemed like a really ripe opportunity because this clinic was identified by both Creighton and CHI as something needing to come with the closing of our hospital that was right next to our campus, which is in a really vulnerable area with people with large needs. That hospital was closing, and the CHI recognized that there was going to be a gap in care. And so the partnership was a great opportunity to bring together these two kind of growing partnerships between the academic center and the health facility. And I think one of the unmeasurable outcomes was that there hadn't been a lot of great shining examples of how this partnership was going to grow and blossom, and this actually shined through the result of the clinic and the work that was being done there, and how it was meeting the needs of the community was a great kind of launching pad for how these two organizations can work together because of our mission. Joy, you give a lot more depth to that.
Yeah, I mean, I can speak, I think, more to the kind of historical context of what was happening, because you're right, that does play into it. So we had a private physicians group at Creighton, and then it merged over with an Allegiant Health and then with CHI. So there was a lot of change, as Megan alluded to, and they decided to relocate our academic medical center, health center, from the community that we're in, which is right next to Creighton and lower income vulnerable, to a different part more west in the city. So building the clinic was done really in partnership with the community as well, around their needs and what they wanted, because it was a big loss to move the hospital. And so there was a lot of intention around, building something that would meet the needs. And then when we first started, we were only really going to have one clinic move. It was decided about 3 weeks before the clinic opened that the other clinic would join. So that was an adventure, but everyone kind of got on board. And so those things played a role in how we do that. And then, they have the refugee contract for the state. It's where the family medicine department practices. So there's family medicine residents there. And that is also a great opportunity to, again, why we think of learners broadly, not just our undergraduate medical education or our health professions, but our graduate medical students, and how we shape them to be change agents for the health system. So there's a lot to our story. I don't know, Carla and Barbara, if there's things you specifically want us to point out that would be helpful.
Well, I'm going to be asked another question, but I also want to say that we will take questions from the other attendees. Yes. As Carla and I keep asking for Joy and Megan to deepen their description of this model.
So one thing that I would like to have you discuss is the fact that I think it was very visionary in how you approached how you were setting this up. So you said this grant opportunity came along at the same time, but and you were bringing two different clinics together, and that does often involve two different cultures. And you also knew, looking back, that neither one of them had very high employee satisfaction at the time. But you're one of the very visionary things was, number one, you were really focusing on the people in that community and what their needs were. But something that you mentioned was that part of the grant, you employed conflict resolution from the start, and you were training everybody in conflict resolution, and you used grant money for that, and that was from the front desk staff to the providers to everybody there. And I want you to talk a little bit about that and the leadership involvement in really getting everybody to that training, but also the fact that why did you not use the money for funding a nurse practitioner, and why and how this was new to introduce also a nurse practitioner into this clinic environment. There's so much here. So
yeah, I think from the conflict resolution piece, that was one of those things that we stumbled upon when our initial group met. Before we knew who was going to be at the clinic, it was Joy, myself. We knew who the person in charge of the clinic was going to be, and he was involved, which was very important. He was very involved from the beginning. And then we had a few other academic people helping, but we knew Joy was very visionary in the sense that she knew bringing these people together was going to be hard. She had been involved kind of in setting the stage years before this all came about. And so we looked into different ideas for how we could build kind of morale and team. And we actually got some consulting fees from outside of our organization that were incredibly high and expensive, and we were like, gosh, is that really where we want to spend all of our money? And so we consulted with some people on our campus, and we're really able to better utilize the resources we had right here at our fingertips and pay them a much more nominal price because they were part of our campus and they had the expertise to do it, and they did a great job. We did 3 trainings over the course of about 18 months. Like Joy mentioned, we did them in these Fifth Friday models, so half of the clinic would come in the morning, half in the afternoon, and they started with just the first training was centered around kind of foundational knowledge of conflict resolution. And then the second training was on approach to conflict and the different types of conflict. And then the third one was all centered around high conflict and how can you diffuse that, types of personalities in high conflict, and recognizing when you're in the high conflict situation. And I think the way they structured that really resonated with every level of personnel. So the front desk staff recognized how that's important when they're triaging patients on the phone or overworking schedules versus the team dynamics as they're in the midst of their busy day. So I think it was really important part of it. Joy can speak maybe.
So, go ahead. What I want to underscore, and this is Barb, is, we often talk about the collaboration, the positive part of our work. What I think Carla and I both were in awe of, that getting out in front of the conflict early. And question, does that have something to do with your clinician outcomes, the satisfaction outcomes today? So go ahead, Joy. I'm going to have another question that I want you to also talk about because I think this is a real major learning for people.
Yeah, I know Megan's still going through the ACE 15 results, so that's an interesting question. If that specific training and what role it played. I'll speak to the nurse practitioner piece that Carla mentioned. So we were, maybe this isn't the right way to say it, but we were kind of pushy that the health system needed to make this commitment if it would be sustainable, and that it made more sense for them to hire the nurse practitioner. So, and as I taught grant writing this morning to the OT students, I said, get everything in writing. So the first letter from the health system said they would support us, but they weren't specific. And we literally said, we're not accepting your support letter and doing this unless you commit to providing the nurse practitioner. And that what's really great is they made that written commitment. When we got the grant, they hired the person, and it's gone really well. And I think there's actually been a really nice domino effect of the recognition and value of nurse practitioners. And they, again, because we started a PA program, instead of hiring a second nurse practitioner, they decided to hire a physician assistant because they wanted the site to represent all of our learners. So, and that was their decision when it came to that. So I think in the Nexus relationship, the positive influence you can have rubbing off on one another But we felt like if we funded the nurse practitioner through the grant, it would be something that the health system can easily say when the grant was over, don't do that. We won't pay for that. And we wanted it to really be sustainable and an engaged member of the team.
So a question, what I want you to now describe, and I have, for those of you on the webinar, this was one of the site visits that I was able to attend, so I know it more deeply than some of the others that we've been showcasing. But one of the things I was also impressed with your work is we have the IPEC competencies. And often we think about that we have to train people in those competencies first in the curriculum, and how do they get, when the question is how do they get reinforced in practice? One of the things I was very impressed with was that you actually had very open conversations about roles and responsibilities, so one of the 4 domains. So could you speak to that, how you helped people understand roles and responsibilities in this implementation early on?
Yeah, we actually continue to do that because we have residents. So one of the ways that it's pretty simple, but we would do the profession of the week at our huddle. And so we pick a profession for the week. And now, since we've been open a couple of years, we do it every July because the new residents are coming, and we profile the profession. And so someone from that profession does a short, like 1 to 2 minute presentation at every huddle for the whole week, talking about what they do and why they do that, patients they've benefited from, what kind of referrals they would benefit from one another. It's been really a simple approach, but a very effective one because people didn't know or understand each other's roles. And as you know, you think about your critical incidents that you talk about, Barbara. I remember a day where we were talking about, to make the collaborative care meetings more efficient, should we really just have the smaller teamlets of people that need to work with the patient meeting? And somebody said, no, because if we don't have some of these professions in the room, they still bring up something when we're discussing that we would miss if we had a smaller and less broad team. And that wasn't said by anyone in the academic, that was said by a clinician. And so for them to, that kind of showed me that they were fully bought into that model. But it's just really simple to show and demonstrate that. The other thing we do is a lot of really intentional handoffs where we show to patients that we work together and know each other. So I've never in my history of practice had physicians or primary care providers come into the clinic to hand off a patient to me, but we literally do that where they will come down and introduce them to the OT and the PT, and it shows the patient that we work together and that we know each other. I've been in situations where, you know, the psychologist is in there in the PT sessions coaching the patients on chronic pain. And so those things started to just spring up. And a lot of times you'll hear the team talk about our collaboration is not named in a time and a day, but it's all the little encounters we have during the day where people communicate with each other. But really the roles and responsibilities, it came out of really talking about what people did and doing those profession spotlights. And because we have learners all the time, we now do them annually and we just rotate through the professions.
So what I want to underscore about what we observed at the site was this weaving every minute of the day, little snippets of learning. So we have competencies, we have, you know, we know what people need to know, but this was a very model practice for strategies for learning, which is very intentional. But I also I'm going to keep asking you questions because I think, you know, we are able to observe things that sometimes you don't see yourself. But I would like for you to describe what a huddle looks like. You, Joy, I believe, told us that everyone wanted to have everyone in the huddle. And I think for most of us, they would be like, really? But I actually went to a huddle. And so if you could describe what that looks like on a daily basis, that would be, I think, very instructive.
Sure. I still attend huddles a couple times a week. Yeah, so our huddles are twice a day. The reason they're twice a day is because our learners rotate so frequently. So we wanted to have 2 a day so that learners could experience, and we shift in who's involved in the team. So we huddle twice a day at 7:45 and 12:45. The huddles are about anywhere from 5 to 10 minutes. At the beginning, they started out longer, and as you become more efficient, they become shorter. We have a conference room where we huddle and gather. We actually have a cowbell that gets people to huddle. And it's a crowded room. Most people are standing. There's a huddle board, and there's someone that leads the huddle that goes through a huddle checklist. And some of that comes from the patients at our medical home, but we've modified it to be incredibly inclusive to everybody. And so they go through safety things from the day. We always start with recognitions and celebrations for team members who did well, and that's really popular and positive. And then we go through announcements. They assign the team assignments during that time. And then anything that needs to come up for discussion. And then on the huddle board, if it's going to take more time, we put it in what's called the parking lot and identify someone to address the issue. And anything and everything can come up. For a long time, people wanted a picnic table. And so that was something in Huddle that was on the list to address so that people could eat outside when it was nice weather. So anything and everything can come up. And that's where you can role model that psychological safety and allow people to express concerns. And so we originally wanted our medical residents to rotate leading the huddles, but we found that certain people are really good at leading huddles and enjoy it. So one of our behavioral health specialists typically runs our huddles. Before she moved on to a different job, it was our imaging person. So they take that task as part of their role and they lead the huddles. One of the really neat things about the huddles that the residency director built in is that it's required for medical residents to attend huddle. It's part of their dashboard and they're held accountable and attendance is taken. So that also starts to build that practice and habit of attending a huddle and being involved in that. So the huddles are, when we were designing learning space and they talked about huddling, I'm like, we need bigger rooms. There's like 25, 30 people at huddles sometimes, depending on who's at the clinic that day and what's going on. So does that cover it, Barbara?
It did. I'm also looking at the time, and again, anyone that has questions to ask the Creighton team, to make sure you type them in. I might say, Sean, I don't know if I'll be able to see them. I'm not in Minnesota, so I'm on a different system. So we'll work this through. But in the meantime, I do have one other question for you to explain to those that are on the webinar. Could you just describe the physical plan? What's the clinic look like? And because the design of the clinic definitely facilitates the collaboration that you've described today.
Yeah, so I helped design the space, and so it's a pod concept, and it sounds kind of silly, but it's based on the Disney concept. So there's a pod, and then there's patient rooms all on the outside, and the clinicians come into the patient exam room from the pod area, which is an open space. There are computers to do documentation, but technically no one really owns the space. It's open space where all the clinicians can collaborate intentionally. And each pod has a conference room that's glassed in so that you can see people meeting in there. And so if people need to have private conversations, they can go in there. Or if learners need didactic, it's set up for that as well. And so essentially the concept is that we can collaborate and have all the magic behind the scenes and then interact with our patients in the patient exam room. And the site has 3 such pods like that on the main floor. And then we were also super intentional in designing even the therapy clinic. One of the features we added is that there's an outdoor walking space and a place to go outside. And our nurse practitioner wanted to have a community garden to help with food insecurity. And so it's great. You can walk out there and engage patients in a real life gardening activity. And that has been built up on the outside. So it was designed for interprofessional collaboration. We looked at a lot of other spaces CHI had done, and they had started to move towards that model. And what worked well, we interviewed people at some of the sites. What do you like about the space? What needs to be bigger or smaller? And so we really built it around that concept. And happy to provide floor plans or pictures of that to anybody that's interested, because it does facilitate collaboration for sure. Do you want to add anything, Megan, that I forgot?
No, I don't think so. There is some community rooms also that are on the first floor, and then there's another pediatric clinic downstairs that wasn't a part of the design of this professional model, but so it's a pretty big building. And then there is a freestanding emergency department that is also part of the building. And there has been work with the interprofessional clinician team on, better collaboration between that and flow of patients to try to maximize patients being seen in the right setting, as well as something that we didn't talk about that Joy did quite a bit of work with was, as you know, with any project, you get over these different barriers. And we identified that documentation of what this team was coming up with was hard to identify in the EMR, to keep, we kept saying we'd see things where we'd come up with a plan for a patient who was frequently using the ED, but what the plan wasn't being well communicated or being able to be seen by those in the ED. And so we were getting kind of incongruent messages to our patients. And so Joy worked very diligently with the team and identified some champions, and they came up with a note template that can be utilized in the EMR. That's a collaborative care note, and that made it more visible, I think, for when patients enter the system outside of just in that clinic.
So Megan and Joy, we're getting a cluster of questions about students. One is, you mentioned medical residents, chaplain residents. A question is, so what other learners are there? Another question is, and for how long? And then another one is, how do you measure the student ability? What kind of measures are you taking, or what kind of assessment, I guess I'll say, for students, and how's that done?
That's good questions. I'll briefly talk about other students. We have nurse practitioner students there. We have therapy students with occupational therapy and physical therapy. We have pharmacy students there. And then we also have some non-Creighton learners there. They have several, I think, MA students that come through from another program. Joy can talk more about it. We did identify as part of when we would do our grant evaluations, our team's stress, I think, centered around, we didn't have great ways to measure our student outcomes because our learners were coming for different periods of time. And so controlling for that variable seemed difficult for that. And Joy can speak she spent many, and I think, sleepless nights trying to figure out onboarding for students, and still is probably not sleeping because of that. Mm-hmm. But she can talk more about it. But that was an identified barrier. And I think to the benefit of the learners identifying that barrier, we're making strides. It's just obviously more complicated than we want it to be.
Yeah, I think there's a lot of learners in the environment, and they're mostly originally they were going for traditional clinical placements, and now we have them going for intentional activities. But for example, those huddles right now, only medical students are going because they were all already onboarded. We can't send any other learners until we address that issue, which we're again going to have addressed next fall. The other thing is that we were intentional about not having learners in the site till the team had time to gel and work together, because we didn't want them to be struggling to role model or teach behaviors that they themselves were not comfortable with. So we kind of gave ourselves a pause on putting learners in the environment. And then actually the clinic team came and said, we're ready for students. So earlier than we anticipated. So we started assigning learners to go over there and to have experiences. And what's really exciting is we have some people now that have even graduated and talk about the experience that they've had and how it shaped them as a clinician, which has been really interesting, and to think about how they're going to take it forward. And we realized that one of the things we needed to do is, because we have so many resources and this is a great environment, that they might not always go to a next clinical environment like that. So start to talk to them about what skills they need to ask the right questions to build their own interprofessional teams, so that they feel equipped to say what they need and how to introduce concepts of working together So we've moved to focusing to some of our education on how do you do this and what does it look like and what will you do when you go to your next clinical site, because we want them to be change agents for the outside of our own health system.
So Joy and Megan, we have a question about patients. If you could describe the population a little bit more, for example, age, Medicare, Medicaid, family focus. What are the distinguishing characteristics of the population?
So family medicine sees everybody birth to death. They have the refugee contract for the state, but the number of refugees being admitted to the United States has gone down since they moved to the clinic. This past year, our institution decided to move student health to the clinic. So that increased our patient population and payer mix. It's essentially all over the place, a lot of diversity, very, not just the refugees, but living in that where it's located. It's in North Omaha. And so a more minority population, but you go over there and you see all kinds of different people. We also didn't have kind of one payer, more Medicaid than Medicare because of the population. But the payer mix is actually pretty broad because you have Creighton employees that go over there. Now you have the students, and then you have the refugee contract and people that saw those physicians that came from those previous clinics often have moved their care there. And so, again, it's incredibly diverse. I don't know if you want to add to that, Megan.
Yeah, I mean, I can speak specifically to Joy, I think, did a great job summarizing what's in the clinic as a whole. As far as the population that we evaluated for our high-risk population, when the clinic opened, we did have 276 patients that qualified, meeting either the 3 or more ED visits in either the first 6 months or the second 6 months, a hemoglobin A1C greater than or equal to 9, or a LACE score greater than or equal to 10. And of those 276 patients, the median age was 53, 42% were male, about 40% were African American, 25% were Asian, and 30% were Caucasian. 70% spoke English, not necessarily as their primary language. And then the refugee population was about 30%. Our primary payer identified through their medical records, about 30% were Medicare and 30% Medicaid, 20% commercial, and 20% uninsured.
Thank you. Are there any other questions? We certainly had a wonderful question and answer. We really appreciate your going off script today, Megan and Joy. Any other questions? If not, Sean, go ahead.
I would just add, if anyone wants to contact me, I know I'll put that out there. If anyone wants to email me or has questions, I'm happy to answer them or share any more information.
The other thing, Joy, that came in, wondering if there's any pictures or diagrams of the clinic that could be shared.
Yep, I have that. If you email me, I can send it to you.
Great. The collaboration space says a lot. So somebody's thanking you for a great presentation. Is there anything else? And Carla, why don't you wrap up telling what's coming next?
Yes. I'm going to go on to the next slide, Sean Diego. So we have webinars scheduled once a month and through, I think it's June or July. And so the next 3 that are coming up are listed here, but they're also on our website. And you can get your full details there. And if you go to the next slide, it shows our, the accelerating, yeah. So it shows, if you go to the National Center's website, which is just nexusipe.org, if you go, you can see at the top, under advancing the drop-down menu shows Accelerating Initiative. If you click on that, you will get just a vast amount of information about this particular initiative. And you can also sign up for the webinar series there. There's program case studies. There's an introductory toolkit, frequently asked questions, all kinds of information about what this whole initiative was about. So I'm hoping that you will go to that website, sign up for future webinars, and join us again next month.
So I'm going to wind this down and thank everyone for joining us today. We archive all of these webinars so that you and your colleagues can access them, and many do. And so we will be with you next month. Thank you.